The following podcast is part of a certified educational activity titled The Evolving Landscape of Fibrosing Interstitial Lung Diseases, Equipping Clinicians to Enhance Patient Care in the Era of Antifibrotic Therapy. Access the entire activity and complete the post-test at peerview.com/XMG860. Downloadable slides and practice aids are also available.
Hello and welcome to this activity on the evolving landscape of fibrosing ILDs. I'm Sherbin Asasi from the UT Health Houston. The goals of our talk today are to improve your understanding of the prevalence, burden of disease, common signs, and symptoms of fibrosing ILDs, equip you with strategies to use current guidelines and recommended methods for the diagnosis and routine assessment of fibrosing ILDs. And lastly, to provide guidance on applying shared decision-making to personalized treatment strategies for patients with fibrosing ILDs that include available and emerging antifibrotics, immunomodulators, and supportive therapies. There are clearly gaps in the diagnosis and management of fibrosing ILDs. Our focus today will be on systemic autoimmune rheumatic disease associated with ILDs, which is SARD-ILD. Those diseases encompass systemic sclerosis, mixed connective tissue disease, rheumatoid arthritis, inflammatory myopathies, and Sjogren's syndrome. In general, ILD in setting of SARDs can have very nonspecific symptoms, such as dry cough, dyspnea on exertion. Crackles may or may not be present. Especially, there's a pattern that I will allude to later, and it is NSIP. And that pattern initially does not have crackles. The differential diagnosis for dyspnea in the setting of SARD-ILD consists of pulmonary and non-pulmonary causes. Obviously, ILD can cause dyspnea, but also pleural effusion, recurrent aspiration, drug-associated pneumonitis, all can cause shortness of breath. Vascular causes can cause shortness of breath, such as pulmonary hypertension, pulmonary embolism, or chronic thromboembolic disease. Extrapulmonary causes of dyspnea would be respiratory muscle weakness, extrinsic chest wall restriction due to skin tightness, as it is seen in systemic sclerosis, heart failure, and lastly, deconditioning or anemia can also cause dyspnea. It's important to point out that high-resolution chest CT is more sensitive than pulmonary function tests alone for screening for ILD. These are results from a SSC cohort showing that around 64 patients had ILD on high-resolution chest CT. 40 out of those 64 had actually normal FVC on PFDs. That means 62.5% of patients with SSC ILD would have been missed if we would have solely relied on PFDs. Hence, the recommendation by ACR chest guidelines is for people with SARD at increased risk of developing ILD to screen with high-resolution chest CT over history and physical examination or PFD alone. So it's really important if you want to screen for ILD to order a high-resolution chest CT. High-resolution chest CT typically also done in prone and supine position to differentiate atelectasis from true increased interstitial marking in the lower lobes. There are dominant patterns associated with different fibrosing ILDs. The non-specific interstitial pneumonia, called also NSIP, is more prevalent in setting of systemic sclerosis, inflammatory myopathies, mixed connective tissue diseases, and Sjogren's syndrome. This pattern has typically ground glass opacity and has a subpleural sparing. Do you see the darker rim in the subpleural space? That is very typical for an NSIP. There is another pattern called usual interstitial pneumonia. This is the typical pattern of another disease called idiopathic pulmonary fibrosis, which is a lung-based disease. It's not a systemic disease. Among SARD ILDs, rheumatoid arthritis is the exception for presenting typically with UIP pattern. While all other SARD ILDs typically present with NSIP, there are always exceptions. Rheumatoid arthritis typically presents with UIP pattern. And UIP pattern typically shows pleural-based changes and has honeycombing. Let's start with a case presentation. John has had a persistent dry cough and exertional dyspnea for 8 months, along with bibasilar inspiratory crackles and a chest X-ray showing increased interstitial markings. ANA, rheumatoid factor, and anti-CCP were all negative. John's medical history includes hypertension, hyperlipidemia. He has no history of joint pain, rashes, muscle weakness, or Raynaud's phenomenon. He has not had significant environmental exposures. So no signs of systemic disease in this case. He's an ex-smoker, 20-pack years, quit around 10 years ago. No family history of autoimmune diseases or ILD. The high-resolution chest CT shows the UIP pattern, which is the pattern that has honeycombing and is pleural-based changes. What is the likely diagnosis in this scenario? The likely diagnosis in this scenario is idiopathic pulmonary fibrosis, abbreviated IPF. This disease is a lung-focused disease, is associated with digital clubbing, has no autoantibodies, is typically associated with UIP pattern, and it has a rapidly progressive course, especially if it's untreated, and doesn't respond to immunosuppression. Whereas SARD ILDs, the diseases that typically are seen in the rheumatology clinic, are multisystem diseases, have autoantibodies, usually present with NSIP pattern, so pleural sparing, subpleural sparing, and ground glass opacity. Please keep in mind that RA-ILD is an exception. SARD ILDs can have variable progression, so a really heterogeneous disease course, and may respond to immunosuppression. How do we differentiate SARD ILDs from the lung-focused IPF? So autoantibodies can be very helpful. Obviously, we usually start with ANA, and we consider a titer of more than 1 to 80 as positive. But we can also look for disease-specific autoantibodies, such as anti-topo, anti-RNA pol, and anti-centromere for SSC, rheumatic factor and anti-CCP for RA, anti-SSC and anti-SSP for Sjogren, or anti-RMP for MCTD. Now there are also extended myositis panels available in commercial labs, which can be ordered to look for anti-synthetase syndrome and anti-MDA5. Other red flags for SARD-ILDs are late onset Raynaud's, inflammatory joint pain, which typically has also a morning stiffness, joint swelling, a typical rash such as a sun-sensitive rash or a typical rash of dermatomyositis or antisynthetase syndrome, proximal muscle weakness, and CPK elevation. Let's talk about Raynaud's phenomenon. In order to diagnose the patient with Raynaud's phenomenon, the patient has to experience color changes in the fingers and toes, up and cold exposure, or stress. And Raynaud's has 3 phases. The first phase, during the first phase, there is a lack of blood flow, so fingers turn white. Then there is lack of oxygen, fingers turn blue, and then the blood gushes in, so fingers turn red. And interestingly, the last phase is the most painful phase. Raynaud's phenomenon is common in the general population. 5 to 15% of the general population has it, but usually it's primary, and the typical age for primary Raynaud's, the typical age of onset is between 15 and 30, but there are also secondary Raynaud's cases, and such as Raynaud's cases associated with systemic sclerosis, antisynthetase syndrome, MCTD, lupus, or Sjogren's syndrome. And the red flags there are late onset Raynaud's. A patient that comes in at the age of 50 and says, my Raynaud's phenomenon started 2 years ago, it's very unlikely that that patient has primary Raynaud's phenomenon. Digital ulcers should not occur in the setting of primary Raynaud's, so is a red flag for secondary Raynaud's, and puffy fingers is another red flag for secondary Raynaud's. I think rheumatologists are familiar with this recommendation. There are now other methods for ANA testing in commercial labs, which rely on multiplex testing. Those methods are not recommended for ANA testing. Based on ACR position statement, ANA testing should be conducted by immunofluorescence using human epithelial type 2 Hep2 cells, because those multiplex testing methods for ANA screening will miss some subtypes of ANA and will not give you a pattern information, which can be very helpful. Let's talk about our general approach to diagnosis, monitoring, and treatment of fibrosing ILDs. Initially, we screen for ILDs with high-resolution chest CT, but also obtain pulmonary function test, serology, to arrive at the diagnosis of SARD-ILD, but also have an idea about the severity of ILD. Typically, for SARD-ILD diagnosis, we don't perform bronchoscopy or lung biopsies because it's not necessary in that setting. but it might be necessary if alternative diagnoses are considered. Once a diagnosis is made, let's say based on symptomatology and serology, let's say we diagnose the patient with systemic sclerosis, then the decision has to be made whether we watch and wait or start treatment. In both scenarios, it's really important to monitor the patient closely for progression. Even if we start the patient on treatment, the patient would need to be still monitored closely, because if there is progression, then the treatment has to be escalated. Let's talk briefly about systemic sclerosis associated ILD. Fibrosis occurs in the alveolar space, impeding the gas exchange. What we typically see on PFTs is a restrictive pattern, basically low FVC, low DLCO, and a normal FEV1 over FVC ratio. SSCID is characterized by NSIP. It's an early disease manifestation and is present in 30 to 50% of SSC patients. If you look at the overall cohort of SSC-ILD patients, the disease course is relatively indolent. However, there is clearly heterogeneity. As seen on the right panel, there is a subgroup that has a really high short-term mortality. And it's important that we differentiate these subgroups and tailor our treatment based on these subgroups. What are the risk factors for progressive ILD in setting of SSC-ILD? Risk factors are anti-topoisomerase positivity, high CRP, higher skin score, African American race, male gender, severe reflux symptoms, higher KL6, which is a serum protein commercially available in Japan and a few other countries, not yet available in US. And it's also important to look at the prior course of disease. If a patient is in the 12 years of the disease and has lost only 10% lung volume the last 12 years, most probably you have more time and you can wait and watch that patient for ILD progression. But if the patient has already lost 20% since diagnosis, which was 2 years ago, that means you have to be much more aggressive with treatment and closely monitor the patient by obtaining PFTs every 6 months and escalating the treatment if there is further progression. What about mixed connective tissue related ILD? Mixed connective tissue diseases have different classification criteria, but all of them require a high titer U1-RMP positivity. Basically, if U1-RMP is negative, that patient cannot be diagnosed with MCTD. MCTD comes in different flavors. Some patients have, for example, scleroderma and lupus overlap. Some patients have scleroderma and myositis overlap, or others have lupus and myositis overlap. But all of them should have U1-RMP positivity. And these different diseases might not appear simultaneously. Patients might present initially more like a lupus patient and then later develop scleroderma and vice versa. What is also important to point out is that there is racial differences in the prevalence of U1RMP and prevalence of NCTD. Patients of East Asian descent and Hispanic ethnicity have a higher prevalence of U1RMP than white patients. Risk factors for ILD in that setting is when the patient has scleroderma-like symptoms, such as dysphagia, Raynaud's phenomenon, and SSC-related autoantibodies, such as anti-SCL70. What about RA-ILD? RA-ILD occurs in nearly 10 to 15% of patients with RA. The predominant pattern is UIP. Risk factors are cigarette smoking, high titer rheumatoid factor, high titer anti-CCP, male sex, older age, and high disease activity. And uncontrolled RA is a risk factor for RA-ILD. Myositis is not a disease that is confined to muscles. It's a systemic disease. Among other manifestations, patients with idiopathic inflammatory myopathies can also have interstitial lung disease. The two subgroups that are associated with rapidly progressive ILD are antisynthetase syndrome and MDA5 dermatomyositis. Antisynthetase syndrome autoantibodies consist of a group of antibodies that target synthetase enzymes which are located in the cytoplasm. So the antigen is in the cytoplasm. So patients can have anti-synthetase antibodies and be ANA negative. The most common one is Jo1, but there are also other antibodies that now can be obtained in an extended myositis panel. The typical symptoms of antisynthetase syndrome is arthritis, mechanic's hand, right, basically rough skin. The most prevalent areas between the first and second finger, Raynaud's, fever, and interstitial lung disease, typically in NSIP pattern. Anti-MDA5 positive myositis is typically amyopathic dermatomyositis, has rapidly progressive ILD. This can be a deadly disease. As associated with pneumomediastinum, arthritis, it's really important to recognize this disease early and treat aggressively. Otherwise, the prognosis is poor. Has very characteristic cutaneous features such as tender gums, oral erosions, palmar papules. They have ulcers on the palms, which is not typical, for example, for systemic sclerosis. There is a recent guideline paper from ACR Chest showing the first-line treatment for SARD-ILDs. Typically, we start with immunosuppressive agents. In case of systemic sclerosis, nintedanib is also mentioned based on the census trial results. It's really important to point out that all these recommendations are conditional. On this slide, there's one strong recommendation, and that is against glucocorticoids for treatment of SSc-ILD, because this can lead to scleroderma renal crisis. Especially treatment with cells in high doses can trigger scleroderma renal crisis in patients with systemic sclerosis. But it's also important, once the treatment is initiated, to monitor these patients carefully for further progression and to escalate the treatment if there is progression. And the recommendation there is either to add or switch another treatment. And several immunosuppressive agents are listed. Nintedanib, the antifibrotic agent nintedanib, is also listed for all disease categories based on inbuilt trial data, which I will show later. For rheumatoid arthritis, pirfenidone is also listed. And again, there is a strong recommendation against usage of glucocorticoids in setting of SSc-ILD. Switching gears to talk about progressive pulmonary fibrosis, abbreviated PPF. This is the scenario where you diagnose the patient with ILD, you start the treatment, monitor the patient carefully, and the patient has worsening ILD despite initial immunosuppressive treatment. And there's no alternative explanation. It cannot be explained, for example, by an opportunistic infection. Occurs in 20 to 30% of SARD ILD patients. And the clinical behavior in that scenario actually resembles IPF. This becomes a rapidly progressive disease. This is shown on this figure, is a observational cohort data showing that on the left panel, generally, CTD-ILD patients, or SARD-ILD patient is the old name for SARD-ILD patient, have a better survival, that is in green line, than, for example, IPF patients in red line. But if they have a decline of more than 10% in FVC, their survival resembles the survival of IPF patients. That is shown on the right panel. So that's important because this requires early recognition and escalation of treatment, because this subgroup has a high mortality. These findings have led to the definition of progressive pulmonary fibrosis by ATS-ERS, which proposes a combination of worsening respiratory symptoms, as reported by the patient, and worsening physiological parameters, basically either worsening of FVC more than 5% or DLCO more than 10% within a last year of follow-up, or radiological evidence of disease progression as listed here. So basically, if the patient has 2 out of 3, let's say, worsening respiratory symptoms and FVC decline more than 5% in the last 1 year, that patient is diagnosed with progressive pulmonary fibrosis. Up to 18 to 32% of patients with non-IPF fibrotic ILDs, which includes SARD ILDs, develop progressive pulmonary fibrosis, abbreviated PPF, within 61 to 80 months of symptom onset. These patients will accumulate irreversible lung damage caused by fibrotic progression, underscoring the importance of early diagnosis and treatment. the importance of early recognition of PPF and escalating treatments, for example, with antifibrotic therapy, is increasingly supported by evidence. Basically, if we intervene early and prevent irreversible damage by escalating the treatment, either adding an antifibrotic therapy or modifying the immunosuppressive therapy, as recommended by ACR CHEST guidelines, we can improve the prognosis of these patients. And in terms of antifibrotics for PPF, nintedanib is the only antifibrotic approved for the treatment of PPF based on the results from the INBELT trial. Pirfenidone is approved for IPF only. Although nintedanib can slow progression, it does not stop progression. Therefore, there is an urgent need for novel treatments that can be used alone or in combination with nintedanib for treatment of PPF. Switching gears to INBELT study. INBELT study is the first study that focused on treatment of PPF. The concept was, regardless of what upstream triggers are, if we have a drug that can treat a common downstream pathway, regardless of whether we are dealing with RA-ILD, SSc-ILD, or hypersensitivity pneumonitis, if we treat that common downstream pathway, we are going to see treatment benefit. So it's a basket trial of fibrosing interstitial disease other than idiopathic pulmonary fibrosis, included SARD-ILD patients. And those patients had to have more than 10% fibrotic changes on high-resolution chest CT and had to have progressive ILD as defined, more than 10% FVC decline in the last 2 years, or a FVC decline between 5 to 10%, and worsening respiratory symptoms, or an increased extent of fibrosis on high-resolution chest CT. The other potential definition for progressive ILD was worsening of respiratory symptoms and increased extent of fibrosis on high-resolution chest CT. So if the patient had one of those criteria, was eligible to be enrolled in INBELT study. It's important to point out that patients treated with immunosuppressive agents such as mycophenolate, cyclophosphamide, and azathioprine were excluded. There was no disease duration cutoff. Patients with long-standing disease could have been enrolled. INBELT study showed that nintedanib slowed the decline in FVC, as shown in this figure, with a relative reduction of 57% in the overall population. That treatment effect was more prominent among patients who had UIP-like fibrotic pattern. There, the relative reduction was 61%. Similar, exactly the same results shown over time. Switching gears to emerging antifibrotic therapies in PPF, there is a recently completed phase 3 clinical trial with nerandomilast. Nerandomilast is an oral phosphodiesterase 4B inhibitor, is a preferential for B inhibitor, which has been shown to have immunomodulatory and antifibrotic effects in preclinical studies. The recently completed phase 3 clinical trial was a 12-month clinical trial of patients with PPF. One arm received placebo, the other arm received nerandomilast 9 mg BID, and the third arm received a higher dose of nerandomilast 18 mg BID. The eligibility criteria mirrored the eligibility criteria of inbuilt study. Patients with ILD other than IPF with a fibrotic lung disease extent of more than 10% on high-resolution chest CT were enrolled if they met one of the following criteria: relative decline in FVC of more than 10%, or a combination of decline in FVC and worsening respiratory symptoms, or increased extent of fibrosis on high-resolution chest CT, or a combination of worsening respiratory symptoms and increased extent of fibrosis on high-resolution chest CT. It's important to point out that background nintedanib treatment was permitted. Approximately 44% of the patients were on background nintedanib, while background with certain immunosuppressive agents such as azathioprine and methotrexate was permitted. Background treatment with mycophenolate, cyclophosphamide, or tocilizumab was not permitted, which is a limitation of this clinical trial. The clinical trial met its primary endpoint. It showed that nerandomilast slows down progression of PPF based on changes in FVC from baseline to week 52 in both doses, both 18 mg PID and nerandomilast 9 mg BID. Interestingly, there was a treatment effect in nerandomilast monotherapy group and in patients taking background nintedanib therapy. The secondary endpoint was time to first acute exacerbation, hospitalization due to respiratory causes or death. There was a numerical benefit for both doses, but it didn't reach the statistical significance. But there's an important finding here that I would like to point out, and that is that both doses reduced mortality during the study period, which is a remarkable result. This is not what we typically see in clinical trials of ILD. Nerandomilast was well tolerated. Focusing on nerandomilast monotherapy group, the group that was not on background nintedanib therapy, the most common side effect was diarrhea. However, the rate of diarrhea in the 9 mg BID dose was very similar to placebo and was around 11% higher in the 18 mg BID group than placebo. In general, the rate of diarrhea was substantially lower with nerandomilast monotherapy in FIBRONEER-ILD trial than with nintedanib in inbuilt trial. The rate of diarrhea in inbuilt was around 67% in the nintedanib treatment group, whereas here is around 27% in 18 milligram BID dose and around 16% in 9 milligram BID dose. It's also important to point out that the rate of upper respiratory tract infections was not higher in the nerandomilast treatment group than placebo, showing that this medication is safe, and that's important for our patients in terms of infection, because many of our patients also are immunosuppressed due to treatments that we provide to them. In general, the rate of discontinuation of study regimen was low. It was actually lower in the nerandomilast treatment group than in placebo. When we focus on nintedanib monotherapy group, just focusing on diarrhea, the frequency of study drug discontinuation due to diarrhea was very low, was 1.4% in the 18 milligram BID dose and was 0 in the 9 milligram BID dose. Juxtaposing this number to nintedanib in inbuilt study, which was around 6%, indicates that this medication most probably has a much lower rate of diarrhea in clinical setting than nintedanib. There are also other emerging antifibrotic therapies that are currently in clinical trials, such as inhaled treprostinil is in a phase 3 trial, and inhaled pirfenidone, which is in a phase 2 trial. It's important that we have a multidisciplinary approach to diagnosis, monitoring, and treatment of fibrosing ILDs. It requires really a partnership among patients, looking at their symptom burden, priorities, risk tolerance, lifestyle consideration, and clinicians building on their experience, building on their disease phenotyping, building on their judgment for considering comorbidities, but also capitalizing on available resources such as guidelines, clinical trial data, and treatment strategies can consist of immunomodulatory therapies, antifibrotics, supportive care such as pulmonary rehab, or supplemental oxygen, enrollment in clinical trials. And if the disease is progressive, patients can also be referred to lung transplant clinics. It's actually important not to wait too long for that referral. Let's continue with a case. Maria was diagnosed with SSC, the diffuse cutaneous subtype, with symptoms beginning 6 months ago. She presented with progressive skin thickening over limbs, trunk, and face. She has puffy fingers, Raynaud's phenomenon, occasional non-productive cough, mild exertional dyspnea. She does not have a history of pulmonary diseases. She has never smoked. She has been found to have ANA positivity, anti-topo positivity, She has mild fatigue, reduced exercise tolerance, and she has the following risk factors for progressive ILD based on this small vignette. She has diffuse cutaneous subtype. She has early disease. She has SCL70 antibody positivity, and she has respiratory symptoms. So how do we manage the monitoring and treatment in this patient? It's really important to obtain a high-resolution chest CT because this is the primary screening tool for ILD in this setting. It's also important to obtain pulmonary function tests at base and ongoing follow-up visits. The findings were, in her case, early ground glass opacities, increased reticulation in the lower lung lobes. PFTs showed an FVC of 75% and DLC of 60%. And in terms of management plan, the patient was initiated on mycophenolate. Typically, the dosage is 2 to 3 grams per day. If the patients don't tolerate mycophenolate mofetil, patients can be switched to mycophenolate sodium, which has less GI side effects. Referral to pulmonologist can be considered. Patient education was provided in regard to symptom monitoring and importance of routine follow-up PFTs. The takeaway message here is that in SCC, early detection allows for earlier treatment and slowing of ILD progression. So it's really important to obtain a high-resolution chest CT at diagnosis, or if there's a change in respiratory symptoms or lung volumes on PFTs in an established patient, it's also important to obtain a high-resolution chest CT in that setting. Let's talk about another case. Edward was diagnosed with RA 5 years ago, with RA-ILD 2 years ago. He was taking methotrexate, but stopped 1 year ago and is now on leflunomide and low-dose prednisone. Edward comes for a follow-up visit and shares that over the past 8 to 10 months, he has experienced increasing shortness of breath, dry cough that is becoming more frequent, needing to rest more after moderate activity. Upon reviewing of his chart, he has a worsening FVC and DLC of more than 10%. He has increased reticulation and subtle new honeycombing compared to the previous high-resolution chest CT. So Edward meets the criteria for PPF based on worsening respiratory symptoms, decline in lung function, and radiographic evidence of fibrotic progression. The question is, how do we adjust his treatment regimen? He's already on immunosuppressive agents, the flunomide. So Edward was started on nintedanib, 150 milligram BID. Nintedanib is associated with diarrhea, so it does require GI monitoring, also requires liver function testing. And he continued his RA management with leflunomide and low-dose prednisone. Currently, nintedanib is the only approved drug for the only approved antifibrotic drug for PPF. But if nerandomilast receives approval from regulatory agencies, Edward would be also a candidate for treatment with nerandomilast. It's also important that Edward is referred to a pulmonologist for multidisciplinary care. So the takeaway message here is that in patients with RA-ILD who have signs of progression based on symptoms, declining PFTs, or fibrotic changes on imaging, um, prompt consideration of antifibrotic therapy is indicated, as immunosuppressive agents alone may not slow disease progression. One can also consider modifying the immunosuppressive regimen based on the ACR CHEST guidelines. Let's switch gears and talk about an initiative by CDC that is focused on training the trainer. And the reason for that is that there are only a few rheumatologists that have a research and clinical focus on SARD-ILDs, but there are many patients in the community that need to be diagnosed, monitored, and treated. So in order to make that happen in an effective and efficient manner, it's important that we train our peers to become trainers themselves, so that they can educate, provide support for other rheumatologists in the community. There, the key is to have effective tools to become trainers in the community. We can provide material that you can share with your colleagues, but also important that when you are having workshops, have workshops that are effective. Consider discussions where you listen to the learners' feedback, to their concerns, try to have interactive sessions, and also support the participants after the workshop. In terms of resources, you can download these slides, but also personalize the educational material depending on your audience and your local needs. For example, obviously, if you're providing education to patients, that's going to be very different than when you're providing education to colleagues. It would be helpful if you have a baseline survey of your participants, because you can identify the educational gaps and then tailor your workshop or your lecture based on those educational gaps. But also, it's important to just not lecture, to have an interactive session that includes also a self-reflection worksheet, and then also provide resources to participants based on their needs after the workshop. In preparation for your workshops, it is important to obtain a baseline survey to identify the gaps present in your community, in recognizing and diagnosing ILD in patients with SARS, and also the necessary skills to care for people with SARD-ILD and PPF, and also to identify the challenges they face in managing people with SARD-ILD and PPF. Furthermore, You can capitalize on available resources such as the slide library, and build in opportunities for discussing, listening, and questions so that the sessions become more interactive. Moreover, inviting a patient can be very helpful in getting the message across about the burden of the disease. And during the workshop, a self-reflection worksheet can help to guide the discussion and help in identifying the biggest challenges in offering evidence-based PPF management in your particular areas, but also capture ideas for overcoming those challenges, and also identifying which additional ongoing support is needed in your community. To summarize, screening patients with SARD in a multidisciplinary team by using PFDs and high-resolution chest CT is key to recognizing ILD as early as possible so that treatment can be initiated in a timely fashion. Some of these patients will develop progressive pulmonary fibrosis despite treatment or do not tolerate currently available treatment. The importance of using antifibrotic therapy in PPF after initial management has failed or was not sufficient to prevent further progression is increasingly supported by evidence. Other antifibrotic treatments are in development that may be able to be used alone or in conjunction with current antifibrotics to improve outcomes for patients with PPF. Lastly, it's important that you spread the word, that you train your colleagues so that we can screen, treat SARD-ILD better, and ultimately improve the lives of people living with PPF. This concludes our session. Thank you so much for joining us.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent medical educational grant from Boehringer Ingelheim Pharmaceuticals, Incorporated. To access all materials for this activity, visit peerview.com/XMG860.